for taking the time to listen to our conversation today about public health in the midst of the coronavirus pandemic. Over the last year, we've seen a lot of challenges related to COVID-19. We've seen the potential rationing of care. We've seen the disparate economic and health impacts of COVID-19 on communities of color and low-income communities. And now we're seeing the challenges related to producing and distributing vaccines in an ethical manner. Today's conversations will look at these issues and get the insight and perspectives of experts in ethics and public policy who will discuss how all of this is playing out on the ground. They'll share the experience of Catholic healthcare providers who have truly been at the forefront of responding to this crisis and how they've sought to apply Catholic social thought to our country's response. My name is Julie Bodnar, and I'm a policy advisor in the USCCB's Office of Domestic Social Development. And today I'm joined by Nate Hibner and Kathy Curran from the Catholic Health Association of the United States, CHA. Nate is Director of Ethics for CHA, where he provides research and suggests ways to implement the Church's moral tradition for member organizations in areas of clinical and organizations ethics. He helps create programming on moral theology and its relationship to current issues for the Catholic health ministry. Nate earned his PhD and Master's in Healthcare Ethics at St. Louis University and holds a bachelor's and master's degree from Boston College. Kathy is Senior Director of Public Policy at CHA, where she coordinates the development of policy positions for the association and interacts with both Congress and the executive branch to promote CHA's advocacy agenda. Previously, she's worked at the USCCB, where she served as Interim Director of the Office of Domestic Social Development and as a policy advisor on health and welfare issues. She's also worked at the U.S. Department of Labor and the U.S. Senate Committee on Health, Education, and Pensions. She practiced law in Boston and has served with the Jesuit Volunteer Corps. Kathy holds a law degree from the University of Virginia and a bachelor's degree from Yale. So we are lucky to have them with us today and to have them serving the Church through their work with CHA. So now let's hear from the experts. We'll go ahead and get started with some questions. Catholic health facilities were the first hospitals to have COVID-19 patients with the very first case in Washington state. So over the last year, what have you seen as some of the ethical and policy challenges of responding to the COVID-19 pandemic?
Well, first off, thank you for having us here. We look forward to this conversation, and we love to be able to discuss the ways that Catholic healthcare responded and continues to respond to this ever-growing medical crisis. At the very beginning, we were faced with unknowns, many unknowns. How transmittable is this virus? How deadly is the virus? What kind of supplies will we need? What kind of treatments might we be able to provide? However, I want to emphasize right at the start that we continue to use the same ethical principles and teachings that we do in times of normalcy. We didn't come up with new ethical principles. We just had new questions, but we were able to stand firmly on the thousands of years of tradition that our Catholic Church has been able to provide. And so we just had to use those principles in a new way. Some of the questions that arose right at the start dealt with things such as insufficient supplies. How do we increase the amount of supplies around personal protective equipment, ventilators, beds, and staffing? Or how do we use them in a more economical way so that we can meet the ever-growing need that we were faced at the very beginning and continue to face today? The other question then had to do with patient population. How do we increase supply but decrease the patients that are within our hospitals? And so that was a communication effort around public health with masks, hand washing, to decrease the number of potential infections, but also about putting a pause on elective surgeries and other procedures so that we could create more availability within our healthcare system. All of these were faced with a sense of justice, equity, the common good, and solidarity. You may have noticed at the beginning, a lot of discussion was around rationing of care and the protocols that were created and put into place nearly 10 years ago for such an epidemic that we're facing. What was unique in this time around was that the broader community were able to read and provide comments on these policies. And so we began to learn how some of them had implicit biases against communities that were disproportionately being affected by the disease. Some of them lacked certain normal capabilities that we found hurdles within the ways that we practice care today. And so we began to listen to our community partners to develop and redevelop and modify these protocols so they could be most effective and most equitable in the way that they're used. So that's where we were. That's kind of the beginning around questions of supplies, around patient population, around the ways that we could increase care and decrease demand.
Well, I guess it's my turn. I'd also like to say thank you for inviting us to be with you today. As Julie said, I used to work at the Bishops' Conference, and social ministry gathering was always the height of the year. Busy and hard to put together, but a lot of fun. And I hope that next year we'll all be able to gather in person again and share that sense of community that is so important at social ministry gathering. So as Nate has said, in the early days, there was a lot of scrambling, trying to figure out, do people have the supplies they need? How can we get more? How can they be distributed? From a policy perspective here in DC, it was pretty crazy trying to track all of the developments that were coming out of HHS and CDC and the administration, and then the developments that were happening on the Hill, and working really hard to try to get the kind of supports that our members and our communities needed to get through this crisis. You know, our hospitals and our long-term care facilities in particularly were hard hit and really scrambling with the shortages of PPE, personal protective equipment, masks and gowns and whatnot. So a lot of lobbying to try to get the resources into our states and into our hospitals so that we could have access to those kinds of supplies that are absolutely essential. And then of course, testing became a really big issue. How can we make sure that our staff had access to testing, our communities have access to testing, all the supplies that are needed for that. We saw a lot of policy development in the area of telehealth, which I think will continue past the emergency. Obviously, as people were discouraged from going to the hospital, elective procedures were canceled. Really, you only needed to go to the hospital if it was an emergency, but you still had healthcare needs. So very quickly, a lot of the rules that had been in place that restricted the payment for healthcare services over telehealth were waived, temporarily waived, so that people could talk to their doctors in their homes, through their phones, through their computers. And I think we'll see a lot more of that as we move forward. People have adapted to that pretty well, but that took a fair amount of work to get rid of some of the regulatory and legal obstacles to that. As I said, a lot of attention was paid to our long-term care facilities. Initially, I don't know if you remember, people thought, well, let's get all the COVID people out of the hospital and put them somewhere together. I know, let's put them in the long-term care facilities. That was an approach in some communities, and obviously that turned out to have pretty bad consequences. Our long-term care facilities tend to be even less well-resourced than hospitals, so trying to make sure that they had access to PPE. And then also because of the decrease in elective procedures, some of our hospitals were having very severe financial situations, potentially bordering on crisis, without the revenue streams in to support the work that they were doing. So it was really important to make sure that we had appropriate funding streams, temporary funding streams for our hospitals so that they could continue to provide services to their communities. And at the same time, we were also really concerned about the general population. Well, people have access to healthcare. People are sick. Not everybody has insurance, even after the ACA. Not everybody has good insurance, even after the ACA. So we've been lobbying for things like special enrollment for ACA marketplace plans, more generous tax credits, increasing the amount of money that the federal government gives to the states in the Medicaid program, so that they would have access to take care of all the people on Medicaid. As people lost their jobs, more people became eligible for Medicaid. And so that was a financial burden on the states. Making sure that it was easier for people to get into Medicaid and stay in Medicaid by not having to constantly re-enroll. Also, a lot of work around immigrants. There was to make sure that all immigrants, documented or undocumented, would have access to testing and treatment and now vaccines for COVID-19. And then we had a lot of concern around other rules like the public charge rule, which had been in place and was discouraging people from getting Medicaid and other kind of healthcare services, which, you know, that presents a threat not only to the individuals, but to the whole community because of community spread. And then trying to bolster the social safety net. All the social determinants of health that are so important: housing, support for homelessness programs, support for nutrition programs. Again, as people lost their jobs, they needed support. We worked on the Paycheck Protection Program, and also making sure that not-for-profit entities had access to those paycheck protection programs so that they could continue to function, because they were the ones who were providing the services to folks. And then fairly quickly, another area of public policy arose. Not a new one, but it was new highlight on the problem of health disparities and systemic racism. We quickly realized that COVID-19 was having a disparate impact on communities of color, other vulnerable populations as well, such as the elderly, but in particular communities of color and low-income communities. And this was partly because essential worker, frontline worker jobs tend to be have greater proportion of people of color in those jobs. So they're not folks who can stay home and work from home. They have to be out there on the front line all the time, partly because of pre-existing health conditions in populations and just because of the health disparities that have been built into the system all along. You know, we know that the impact on these communities has just been terrible. Black, Hispanic, and Native Americans are hospitalized at about 4 times the rate of white folks with COVID-19 and have higher mortality rates, upwards of 2 to 3% higher mortality rates. So the impact on communities of color has been very severe, and trying to address that through public policy has been a large focus of our work.
Thank you. Clearly, the last year has been busy and trying for health providers everywhere. But in recent weeks, we've seen a glimpse of what we hope is a light at the end of the tunnel with the approval of some COVID-19 vaccines. The principles of Catholic social teaching have a lot to offer in how we approach vaccine production and distribution. I guess the question is, have you been able to communicate those principles in your work? Have you been able to have those principles influence your work?
Excellent question. Yes, we now are on to a world with a COVID vaccine, which is a glimmer of hope. However, it's new, and therefore we have new questions in how do we approach it. Again, using well-established ethical principles that we've used for decades within Catholic healthcare in the United States. Principles such as common good, subsidiarity, solidarity, care for the vulnerable and the poor. The initial questions around the vaccine were around their safety and their effectiveness. I think through the trials, we have kind of shown conclusively that for the majority of people across the world, they are safe and they are incredibly effective for a vaccine of any kind. Upwards of 95% is quite an effective rate for a vaccine. We also had questions because as Catholics, we are worried about the production of vaccines using technologies that stem from abortion decades in the past. But thankfully, the bishops' conferences across the globe, as well as the Vatican, had conclusively said that these are morally acceptable for Catholics to take and to use. In those documents, especially the one by the Vatican that sees a global view of vaccines, they often raised Catholic social teaching principles as the very kind of means in which we should be distributing the vaccine to the entire population. Another concern is, again, just now we're on to distribution. Who gets it? How do they get it? Who gets it first? These are all questions of justice, equity. Kathy mentioned the number of populations that have been unequally affected by COVID. And so how do we help to alleviate some of that injustice that the disease has brought to bear? How can we use the vaccine in a way that promotes the common good? How do we continue to protect those who are most vulnerable, either because they medically cannot receive the vaccine or because they're on the front lines on a daily basis? These are continued questions that we're going to have. The challenge is, and I think Kathy will be able to highlight some of this, is how do we implement this? We have really great ideas. We have principles that we want to utilize. We want to promote the Catholic social teaching in the way that we distribute vaccines. However, reality continues to put up roadblocks. And so we have to work together. The pandemic has certainly shown the need for solidarity and the efforts of a community response. And the vaccine distribution only continues to add towards that need. And so those are some of the general Catholic social teachings that we've used in our discussions, in our policy creations, and in our debates about vaccine production and distribution. And so now I turn it to Kathy to discuss some of the more policy initiatives that Catholic Healthcare has done so far on this regard.
We were paying pretty close attention to the issue of vaccine development and distribution from the beginning. Nate and our ethics team, of course, being concerned to understand how vaccines were produced so that we could be confident that there were no moral or ethical issues involved. And then, the idea of how are we going to distribute vaccines? So on the policy side, our sort of first policy outing was in July. Our president and CEO, Sister Mary Haddad, put out a statement on vaccine equity and Catholic principles for the common good. And based upon Catholic social teaching, that sort of outlined the principles we thought that should apply as we are developing and then distributing vaccines. Things like safety, making sure that there was equal, appropriate representation of different kinds of populations during the trials. We talked also about making sure that there was equity internationally, so that the powerful and rich nations weren't hogging up all the vaccines and all the treatment, and then making sure that, as I said, as we had by then become very much aware of the disparate impact on minority populations, making sure that essential workers, frontline workers, and minority populations were given priority for vaccine access. And then we use those principles to write comment letters and weigh in the policy debate with the different commissions at the Centers for Disease Control and the FDA, whose job it was to come up with the recommendations for how distribution would happen. And I think we were pretty pleased with what they came up with. I think the framework for distribution that emerged does reflect principles of Catholic social teaching, but they're focusing on healthcare workers, which of course is necessary to make sure that the healthcare system stays operable, and then focusing on populations and long-term care facilities and other essential workers. They didn't call out necessarily prioritizing certain demographic populations or racial populations, but as I said before, because so many of the people who are disproportionately affected by COVID-19 are in frontline jobs, it was really important that they be prioritized. So that's gone really well. One of the challenges we have with the vaccine now is vaccine hesitancy. And there's a high degree of vaccine hesitancy in the country at large, but in particular among minority populations and in particular among Black Americans. Some of the survey data shows that, consistently the reluctance among African Americans to get COVID vaccine is 10 to 15 percentage points higher than the general population. And of course, there are some good reasons for that. There's not a very great history of our healthcare system and interaction with folks of color, from the infamous Tuskegee experiments to just the difficulties that African Americans and other people of color have accessing healthcare. I thought one interesting anecdote that I read about was that presidents of two historically Black colleges, took a really aggressive approach at encouraging their students and faculty and communities to get COVID-19. And they wrote about how surprised they were at the pushback they got. People, not happy with them for encouraging their community to get vaccine because of the deep, deep wells of distrust. So our members have really been trying, our CHA members have been trying to take steps to really focus on COVID health equity, whether it's Peace Health out on the West Coast, running, working with local churches and community groups to target African Americans and Hispanics for testing, to an effort to make sure that in our facilities, the African American leaders, you know, we publicize when they're getting testing, so that vaccines, so that they, you know, they can have leadership roles in their communities and try to increase the trust in populations. And we're in the healthcare world, we're finding that the same problem among healthcare workers, that it tends to be higher. There tends to be higher degrees of reluctance among minority employees, and we're working generally. Our members are finding a huge logistical challenge in just getting all of their employees, their healthcare workers, vaccinated. And so they're really working together, all different systems in different parts of the country, to be able to coordinate their activities and reach out to members. Of course, a lot of these systems have hospitals in multiple states. A lot of people, physicians, are working remotely. So, you know, trying to really coordinate our efforts to make sure that our own employees are vaccinated, so that they can be confident, and the patients can be confident in the treatment that they receive. But then also working with our communities to make sure that there's access to vaccines, and both in terms of putting vaccine sites where people can actually reach them, and testing sites where people can reach them, don't have transportation issues, for example. And then also, of course, making sure the cost issue is taken care of. You know, I think we have optimism about the vaccines are here, but we still have a lot of work to do to get those shots in the arms. And, you know, working with particularly state and local entities to in coordinating these activities is also a very important piece of the picture.
Thank you. I mean, obviously, we're still in the midst of it. The COVID-19 pandemic is still all around us. So there are still challenges and opportunities ahead. As we look forward, what are some of those? What are some of the challenges and opportunities to address this pandemic, and what are some of the lessons we've learned?
I'm going to let Kathy go first on this one.
Wow, challenges and lessons. Well, I mean, one of the things I work a lot on is health disparities, so I want to talk about that for a second. And, you know, back, I can't believe it's been almost a year. You know, April, May, when the data first started coming out, and people were like, you know, shocked. It was big news that the COVID-19 had a disparate impact on communities of color, and they were finding it harder to get treatment. And for those of us who've been working in the areas of health disparities and systemic racism, it wasn't really news to us, but it's good to know that these issues, the underlying issues that have been creating health disparities in our health system for decades, are now front and center. And so I think an opportunity is, if we can maintain the focus on health disparities and why we have health disparities. So, you know, access to the social determinants of health is unequal. We see just in COVID-19, for example, when people started getting their jobs back, you know, and when there was economic recovery to some extent, that wasn't shared by minorities of color. The economic hardship due to coronavirus hit those communities a lot harder. And that challenges around education, income, access to care, those are all greater challenges in communities of color, and we need to address those because those contribute to health. We need to address the issue of health disparities to the extent there are problems within our facilities. We need to be very conscious of things like unconscious bias and disparate impact of access to treatment. But we also need to be paying attention to what's happening out in our communities to make sure that people have access early on to all the social supports they need to make sure that they have the health access to optimal health that they are entitled to, that we believe everyone is entitled to because of we recognize the inherent dignity of every person. So we have a lot of work to do in addressing health disparities and making sure there's equal access and equal outcomes. And I think that's one thing that's both a challenge and an opportunity we found in COVID-19.
I would say there are three. I'm going to highlight three continuing challenges. Two on the immediate side, one more long term, and it touches upon what Kathy just mentioned. And the first two immediate is we're having more infections, we are having higher rates of death. We have daily death rates that are more than we have seen in the entire pandemic. So we're nowhere out of the woods when it comes to the actual disease itself. And our hospitals are getting pushed even more and more closer to the limit that they can do, not only because of PPE and medications and beds, but we're seeing a huge shortage in staff. You know, these people have been working nonstop, essentially, for the last 9 months, faced with death, faced with hardships and tragedies, and we're continuing to ask them to push ahead. And unfortunately, that's causing burnout. That's causing people who are getting sick and unable to continue their work. And so the shortage of staff is becoming a major concern, as well as just their general well-being. We want them to be healthy and strong so we can continue to fight this cause. The next one is the vaccine distribution that we kind of mentioned in question 2. How do we get more vaccine? How do we get it to the people that need it? How do we get people to actually take it? Questions around, as Kathy mentioned, subsidiarity. How do you get the communities that are most effective to help them take charge on ensuring vaccines are available to their neighbors and loved ones? That's a huge concern. We're not over yet. The longer concern is, I mean, just listen, if you go back and listen to the question, the first question, and Kathy's response on the number of kind of stopgaps that had to be put in place because of the numerous holes within our health system is a long-term problem. I mean, I feel as if we are the Dutch boy with our fingers in the dam right now, but those are only temporary solutions. The questions of disparity, access, cost are going to continue to linger with us well past this pandemic. And we just happen to have just seen them in a brighter, more contrasting way because of the greater concern and need in the last 9 months. So we need to make sure we have a community effort around fixing the problems in our healthcare system that make it difficult and challenging for people to live well, for people to, flourish as human beings, and for our community to continue to be strong when we're faced with a viral disease that we will sure again face decades, hopefully centuries from now, but that we should be able to face in a more effective and better way than we have. So those are the three I would really highlight as continued challenges from today.
If we have a couple minutes left, I wanted to pick up on Nate's theme of community and maybe leave with on a note of opportunity and challenge in the good sense, challenging us to really do more. So, it's really important that we work with our community leaders, not go into communities and tell them what we think they need, but working with leaders in the Black community, the Latinx community, and all the different communities and groups of people that are living in our areas, and listen to them about what they need, and really build, to get back to the concept of Catholic social teaching, really build sort of just and meaningful relationships with them, and help listen to what their needs are and build those into the work that we do. And that's a really important element, I think, of a broader goal that we are all committing to, I think, more and more, certainly in Catholic healthcare, of really achieving true health equity and really dealing with some of the underlying issues that still exist in our society around systemic racism. And that's going to require just relationships in our communities. It's going to require we as healthcare and other institutions really taking a look inside at how we do business and how we can do better. And then, of course, working with others to advocate for change in policies at state and local and national levels. And so right now we're focusing on COVID because that's what we need to focus on. But coming out of it, I hope that we can be working towards really making some progress around some of the issues that have been facing us in terms of health disparities, and as Nate said, in terms of our public health system, and what we really need to do to have a vibrant health system and that is ready to meet the needs and achieve optimal health for all of our citizens.
Well, thank you. I think you did a wonderful job tying this all together with the theme of rebuilding together and why we're gathering here with CSMG. So thank you for your insights and for being with us today. And thank you for the work that you've done and that you'll continue to do on these issues. And we look forward to talking with you again and having you answer some questions during CSMG. So please, everyone that's watching, please join us on Monday, February 8th at 4:45. We'll have Kathy and Nate here again to answer your questions. Thank you.
Thank you.
Thank you.